Acute liver failure. Introduction. Acute liver failure is characterized by rapid deterioration of liver function resulting in altered mentation and coagulopathy in previously normal individuals. The simplest definition requires evidence of coagulopathy, usually an INR greater than 1.5, and any degree of encephalopathy in a patient without pre-existing cirrhosis and with an illness of less than 26 weeks duration. It is most commonly caused by paracetamol overdose, other drug-induced liver injury or viral hepatitis, but in 20% of cases the cause remains unknown. Table 25. Overall short-term survival with liver transplantation is greater than 65%. NB. Acute liver failure is rare and carries a high mortality. Early recognition, early and aggressive fluid resuscitation, and early liaison with a specialist liver unit improves outcomes. History of the presenting problem. If severe encephalopathy is present, the patient will not be able to give a reliable history, and information, if any is available, will have to come entirely from family or friends. In this case, the diagnosis and cause of the problem seem reasonably clear-cut, but this will not always be so, and it is necessary to determine if the presenting problem is acute liver failure, if so what the likely cause is, and whether there is a background of chronic liver disease. Cause of acute liver failure. Has there been exposure to viral infection, drugs, or other toxins? In this case, the circumstances strongly suggest paracetamol overdose, but it is always appropriate to explore the following. Is there any possibility that the patient may have taken paracetamol, and if so, how much and over how long a period? Has the patient recently been suicidal? Any previous overdoses? Consider the other diagnoses listed in Table 25. Is the patient at risk of any of these? A full drug history is required. What medications, prescribed and over-the-counter, have been taken in the last few weeks? Is the patient at risk of viral hepatitis? Has she traveled overseas recently? NB. Occasionally paracetamol overdose can occur unintentionally, with the drug taken over several days for medicinal purposes. Liver damage due to paracetamol is potentiated by concomitant alcoholic liver disease, malnutrition, and some regular medications, e.g. phenytoin. Always take a very careful history of drug use. Acute liver failure. Other important questions. Visual hallucinations. If these are associated with confusion, consider alcohol withdrawal in the differential diagnosis. Epileptic fits. These usually reflect alcohol withdrawal or focal cerebral disease, but seizures can occur at any stage of encephalopathy, and unrecognized hypoglycemia must be excluded. Onset of confusion in relation to any history of jaundice. Hepatic encephalopathy usually follows jaundice, and the time from onset of jaundice to encephalopathy is of prognostic significance. In paracetamol hepatotoxicity, encephalopathy typically occurs within 24-48 hours of jaundice and within 48-96 hours of the overdose. Abdominal pain. Acute liver failure rarely causes pain, but there may be mild right-sided abdominal discomfort. If pain is prominent, consider hepatic vein occlusion, Budd-Chiari syndrome. In paracetamol overdose, the pain typically subsides as the patient gets better. NB. Differential diagnosis of the patient with acute liver failure. Important issues in the history. Drug hepatotoxicity, exposure to any new drug, particularly an NSAID, in the 2 weeks preceding onset of jaundice. Remember that it is important to exclude non-proprietary drugs such as herbal remedies. Viral hepatitis. Risk factors for exposure to hepatitis B, e.g. in prostitutes, homosexuals, intravenous drug abusers and with use of potentially infected blood products from abroad. Wilson's disease. If less than 40 years old, there may be a family history and/or chronic neurological symptoms, e.g. tremor, change in handwriting. Autoimmune chronic active hepatitis must always be excluded, particularly in middle-aged women. Look for a previous medical history or family history of other autoimmune conditions, e.g. thyroid disease, rheumatoid arthritis. Leptospirosis, Weil's disease. If occupational or recreational exposure to stagnant water, look for myalgia and red eyes. Heart failure and ischemic hepatitis can mimic acute liver failure. When a patient develops acute liver failure in hospital, always look carefully in the medical and nursing records for documented periods of hypotension prior to presentation. Malignant infiltration of the liver by cancer or lymphoma can occasionally present as acute liver failure. Chronic liver disease. Is there a history of chronic confusion and/or poor concentration? This does not occur in acute liver failure and suggests chronic liver disease in this context. Has the patient got chronic liver disease or is she at risk of this? Other relevant history. Patients with acute liver failure may eventually need super-urgent liver transplantation. Particularly in paracetamol overdose, it is useful to gather as much history as possible from relatives, friends, and the patient's own GP about previous health and contact with the medical profession. Examination. General features. NB. If the patient is nearly dead, unrecordable BP, thready pulse, depressed conscious level, call immediately for help from the intensive care unit. Check vital signs. Look in particular for evidence of volume depletion, cool peripheries, tachycardia, hypotension, postural hypotension, low JVP. Check pulse oximetry. In the early stages of acute hepatic failure, vital signs are normal. Late features include tachycardia and hypotension. A rising BP and a falling pulse rate are very late signs that indicate cerebral edema and are associated with a poor prognosis. NB. If the patient is peripherally shut down and hypotensive, insert 2 large bore cannulae and start resuscitation immediately whilst completing the history and examination. Check Glasgow Coma Scale, GCS, score grades hepatic encephalopathy. This is the hallmark of fulminant hepatic failure and comprises a spectrum of neuropsychiatric abnormalities in patients with liver dysfunction in the absence of other known brain disease. There are characteristic personality changes, intellectual impairment, and a depressed level of consciousness. Note that focal neurological signs are not expected and their presence should alert to the possibility of a focal cerebral lesion, with intracerebral hemorrhage likely in this context. Decorticate or decerebrate posture and fixed pupils are late signs of irreversible cerebral edema. NB. Grades of hepatic encephalopathy. Grade I, altered mood, impaired concentration, and psychomotor function. Grade 2, drowsy, inappropriate behavior, able to talk. Grade 3, very drowsy, disorientated, agitated, aggressive. Grade 4, coma, may respond to painful stimuli. NB. The onset of confusion or drowsiness in a patient with acute liver injury is ominous and necessitates advice from a liver unit. Stigmata of chronic liver disease. Jaundice is often but not always seen at presentation with acute liver failure. Look for clues to risk behavior, e.g. tattoos, injection sites, previous evidence of self-harm. If the patient is less than 40 years old, consider an ophthalmic slit lamp examination for Kaiser-Fleischer rings of Wilson's disease. Look for signs of masquerading non-hepatic illnesses such as sepsis, heart failure, and disseminated malignancy. NB. Development of bilateral subconjunctival hemorrhages seems to be a feature peculiar to paracetamol-associated liver failure and should raise suspicion of this diagnosis in patients presenting late. Abdomen. Right upper quadrant tenderness may be present. If the liver cannot be palpated, or the normal hepatic dullness cannot be detected by percussion, this may be indicative of decreased liver volume due to massive hepatocyte loss. An enlarged liver may be seen early in viral hepatitis or with malignant infiltration, congestive heart failure or acute Budd-Chiari syndrome. Note that ascites would be very unusual in paracetamol poisoning but may occur with more gradual onset of acute hepatic insufficiency, i.e. so-called subacute liver failure. Investigation. Routine tests in any very ill patient. FBC, clotting screen INR, electrolytes, glucose, renal liver, bone function tests, magnesium, amylase, lipase, C-reactive protein, CRP, blood group and SAVE. Blood, urine, and sputum cultures. Arterial blood gases and lactate. Pregnancy test, if appropriate. In the context of the patient with acute liver failure, look particularly for evidence of synthetic failure, coagulopathy, hypoglycemia, and concurrent renal and/or respiratory failure. Hypoatremia is common. 1/3 of patients with acute liver failure have pancreatitis at autopsy. Note that marked elevations in CRP are not in keeping with fulminant liver failure. If found, consider the possibility of sepsis as the primary illness and remember that this is a leading cause of death in acute liver failure. In paracetamol overdose, an arterial lactate concentration greater than 3.5 mol/L early, 4 hours, after admission to a liver unit or greater than 3.0 mol/L after fluid resuscitation, 12 hours after admission, identifies patients who are likely to die early and who would therefore potentially benefit from transplantation. There is a high mortality of fulminant hepatitis E in pregnant women. NB. The liver function tests themselves may aid in understanding the etiology of liver disease, but the transaminase level itself is of no prognostic significance and just indicates liver cell damage. NB. Where the prothrombin time, PT, in seconds is greater than the time after a paracetamol overdose, in hours, e.g. a PT of 40 seconds 30 hours after the overdose as opposed to a PT of 50 seconds 60 hours after the overdose, there is a particular risk of developing liver failure. Blood tests to determine the cause of acute liver failure. These should clearly be determined by the clinical context. In some instances, such as the case described here, the diagnosis will be clear-cut and extensive investigation is not required to establish the cause of liver failure, but where the cause is not obvious the following would be appropriate. Paracetamol level. Toxicology screen as appropriate. Viral hepatitis serology, anti-HAV IgM, HBsAg, anti-HBc IgM, anti-HEV, anti-HCV, extended screen if these are negative and no other diagnosis established, including herpes simplex virus, HSV, cytomegalovirus, CMV, Epstein-Barr virus, adenovirus, parvovirus B19. Ceruloplasmin level, if patient less than 40 years. Autoimmune markers, antinuclear antibodies, liver antibodies, immunoglobulin levels. HIV status. Leptospiral serology. NB. Surface antigen is cleared from the serum by the time of presentation with jaundice in up to 5% of patients with fulminant hepatitis due to hepatitis B virus. Diagnosis therefore rests on an appropriate pattern of antibody response, e.g. IgM anticore, or DNA levels. Abdominal imaging. Ultrasound is particularly useful to look for evidence of background chronic liver disease, splenomegaly, varices, ascites, portal vein thrombosis, and it is also the first-line investigation if Budd-Chiari syndrome is suspected. Cross-sectional imaging with CT should be performed if the patient is stable enough and the diagnosis is at all in doubt. Management. Early involvement of specialist hepatology services is important in managing patients with acute liver failure. The key aspects of management include the following. Oxygenation. Give high-flow oxygen to maintain arterial saturation greater than 92%. Treat and prevent hypovolemia. Use 4.5% albumin, rather than 0.9% saline in this context. Treat and prevent hypoglycemia. Give 10% dextrose, or, if needed, and by a central line, 50% dextrose, at a rate to keep finger prick blood glucose in the range 4-7 mol/L. Correct electrolyte abnormalities, including phosphate, but note that hypoatriemia is due to water excess and not to sodium deficiency and should not be treated by infusion of saline. Monitor renal function closely. Renal replacement therapy should be instituted sooner rather than later if the patient develops renal failure. Avoid unnecessary medications, in particular NSAIDs, diuretics, opiates, and sedatives. Enteral or parenteral nutrition should be initiated without delay. N-acetylcysteine. Give 150 mg/kg in 1L 5% dextrose over 24 hours. Note different regimen if given as a specific antidote to paracetamol toxicity, see below. Prophylaxis against sepsis. Give broad-spectrum antibiotics and fluconazole. Prophylaxis against gastrointestinal stress ulceration, e.g. ranitidine, or omeprazole. Consider treatments to minimize absorption of nitrogenous substances from the gut, not used in all liver centers disaccharide laxative, e.g. lactulose, in a dose sufficient to produce 2 to 3 soft stools daily. Enemas, broad-spectrum poorly absorbed antibiotic, e.g. neomycin 1 gram QDS by mouth. NB. Avoid precipitating Wernicke's encephalopathy. If there is a history of high alcohol intake or malnourishment, give thiamine intravenously before giving glucose, e.g. Pabrinex, thiamine, intravenous high potency, 10 ml over 10 minutes 3 times daily. NB. Do not routinely correct coagulopathy. Bleeding is rare in acute liver failure and the PT is an important prognostic indicator. Hepatic encephalopathy. The patient's neurological status must be reviewed regularly. If hepatic encephalopathy develops, progression from grade 1 to grade 4 and development of cerebral edema may occur within an hour or two. Patients who are agitated or aggressive may need ventilation to enable care to be given. Those with grade 3 or 4 encephalopathy should be ventilated electively because of the risk of cerebral edema, and those with grade 2 encephalopathy should be considered for ventilation to facilitate safe transfer to a liver unit. Cerebral edema is not likely in patients with grade 1 to 2 encephalopathy, but with progression to grade 3 the risk increases to 25-35% and with grade 4 coma to 65-75% or more. The signs of hypertension, bradycardia, and irregular respirations, Cushing's triad, are not uniformly present. These and other neurological changes such as pupillary dilatation or signs of decerebration are typically evident only late in the course. Liver units vary in their monitoring for and management of this condition, but many will directly measure cerebral perfusion pressure, CPP, and intracranial pressure, ICP, maintaining ICP below 20-25 mmHg and CPP above 50-60 mmHg if possible. Strategies for care include nursing at 20-30 degree, hyperventilation to reduce CO2, controlled hypothermia, mannitol boluses, 0.51 g/kg repeated as long as serum osmolality less than 320 ms/mol/L, controlled hypernatremia, boluses of 30% hypertonic saline to maintain serum sodium 145-155 mol/L, and occasionally short-acting barbiturates such as thiopental. Specific treatments. Paracetamol overdose. Liver failure from paracetamol overdose is preventable if the patient presents early and N-acetylcysteine is correctly administered, and this treatment improves prognosis even in those who present over 16 hours afterwards. Following loading, 150 mg/kg for over 15 minutes followed by 50 mg/kg over 4 hours. Continue maintenance dose of 150 mg/kg for 24 hours, which can be given as a concentrated solution if there is a problem with fluid overload. If appropriate, refer the patient to a specialist center. Table 28. NB. Paracetamol overdose. If in doubt, give N-acetylcysteine. Other causes of acute liver failure. Other specific therapies will depend on the particular diagnosis, e.g. prednisolone in autoimmune hepatitis, lamivudine in hepatitis B, acyclovir in HSV or varicella infection, ganciclovir in CMV infection, delivery in pregnancy-associated disease. Clearly, such management needs to be carefully discussed with a hepatologist. Further comments. Criteria for liver transplantation. Urgent hepatic transplantation is indicated in acute liver failure where prognostic indicators suggest a high likelihood of death. Classically, those listed for super-urgent liver transplantation are predicted to have a survival of less than 3 days without a new organ. The King's College criteria recommend transplantation in the following circumstances. Paracetamol-induced acute liver failure, arterial pH less than 7.3 following adequate volume resuscitation, irrespective of coma grade, or PT greater than 100 seconds, INR greater than 6.5, and serum creatinine greater than 300 mol/L in patients in grade 3 or 4 coma. Non-paracetamol-induced acute liver failure, PT greater than 100 seconds, irrespective of coma grade, or any 3 of the following, irrespective of coma grade drug toxicity and indeterminate cause of acute liver failure, age less than 10 years or greater than 40 years, jaundice to coma interval greater than 7 days, PT greater than 50 seconds, INR greater than 3.5, serum bilirubin greater than 300 mol/L. Amendments continue to be suggested and prognostic markers such as lactate, alpha-fetoprotein, phosphate and factor V levels have been used by some.